My dear friends, just one word can change all the presentation. Here, the word is subscapularis. In November, I was in Varsovie, and it was the same title, but antero-superior tears. So it's totally different. But I think this word is much more important, irreparable, because most of the time you can repair the subscap. So my first question when I think about this presentation, because it was different than the previous one, does isolated subscap tears really exist? Because if you look at the paper of Philip Collin, there is no isolated subscap lesion. It does not exist. But the subscap is involved in the rupture between 19 to 49% of the cases. Nevertheless, fortunately, I know this lesion does exist because I've seen that. You can see some papers about that. But for sure, the incidence is very low, 5%. So 5% of isolated subscap versus 50% of involved with another tendon. This is very important to understand. And this is the patient I've operated in Barcelona, patient of HM. For me, it was an isolated subscap tear with a normal supraspinatus, and it is what I call the isolated loss of internal rotation. So this is the outline of my presentation. When to consider irreparable, what are the indications, but more important, what are the contraindications, and what are the tendon transfer we can use, what is the technique. The rule number one, as you know, you can repair the subscap most of the time. If you find the coma sign, it's fantastic, because if you find the coma sign, if there is a coma sign, it's very strong. It is the key to success, the key to reduction. You don't have to cut the coma between the subscap and the supraspinatus because it's very strong. It is the anatomical part of your reduction. You just have to put a suture just around to reduce in the same way both the subscap and the supraspinatus, and then you have to put just anchor to finish. What is the coma sign? Just to remind you, it's a junction between the supraspinatus and the subscap. It is made by the coracal ligament. Thank you. Yes, sorry for that. And it's fantastic because this coma sign just stop the retraction, the medial retraction of both the subscap and the supraspinatus, and the subscap cannot be medialized too much. It's very easy to reduce it. So this is what you have done. What you have to do, you have to keep it safe, and in that situation, it's fantastic. And most of the times, when you have that, you have a very good result. When you have an isolated subscap tear, like in this paper, if you repair or if you don't repair, the result is not really different. And for sure, in this paper, there was a fat infiltration more than 3, and you can imagine, of course, that the repair probably is not very useful. So when to consider the subscap irreparable? So this is, for example, one example, but in that situation, I've decided to take both subscap and supraspinatus, but already operated with a fat infiltration and glenoid retraction. In that situation, I will not try again. So, but why worry about the subscap? This is the classification of Laurent Lafosse. And first of all, you have a rupture of the subscap, maybe a traumatic one. And if you forget this lesion, if you leave a patient because the physio is not so bad, he recovers, as we've seen this morning, he recovers, but not a full recovery. Then in that situation, I think, this is just an hypothesis, there is a posterior retraction of the soft tissue and especially the capsule. And then with time, if you leave it, you will have an anterior, not an anterior superior, but an anterior subluxation or translation of the head. And in that situation, you may have static instability of the shoulder, dynamic and then static, and it's too late because you will not be able to restore this function. So what are the good prognostic factors? Of course, a traumatic case, if you make an acute surgery, the coma sign, a fat inflation less than 3, no anterior subluxation, and a good general condition of your patient. On the opposite, the bad prognostic factor will be degenerative, chronic, no coma, fat infiltration, static anterior subluxation, smoke, cholesterol, obesity, and failed previous repair. In the first case, for sure, you can repair, and you should repair, you must repair, and most of the time you will have a good result. On the opposite, if you are here, the tendon transfer can be an option, but sometimes it's not a good indication. This is, for me, a good indication. The isolated loss of interrotation. You have a good flexible shoulder, good passive range of motion, good elevation, but no active internal rotation. It is an isolated subscap tear with a good passive range of motion. It's a type 4 subscap tear, and then you can do a tendon transfer. For me, this is for sure a contraindication, and my next presentation will be a discussion with what is a true steatopathic shoulder. But in that situation, it is a combined loss of elevation and interrotation, and for sure, in that situation, it's a bad idea. You have an anterior and superior escape. In that situation, it's a dynamic one. That means passively you can reach all the directions, but actively there is a superior escape of the shoulder because there is no anterior wall, anterior superior wall. So this is a contraindication of a tendon transfer. For me, there is only one way. It is the reverse, plus or minus a tendon transfer with a pec major. This is just if you want to make a tendon transfer to improve internal rotation, but I'm not sure it works fantastic. This is for me another point. When you see on the right this lady, she has a static anterior or superior escape of the shoulder. It's too late for me because you are not able passively to reduce the shoulder. So how can your tendon transfer will be strong enough to restore this belly press test? So I think this is the reason why most of the tendon transfer anteriorly, like the lat dorsi, cannot restore or negative the belly press test because probably you have a posterior retraction of the capsule, which is a chronic case, and which make the inefficient your tendon transfer. And finally, we have three options, as you know. We have a pec minor, we have a pec major, and we have the lat dorsi plus or minus the teres major. You can combine both together. First of all, the pec minor can be a good option, but it's not probably the best one for different reasons. It's short, it's very weak, and the line of pull is not very good because it comes from the anterior part of the chest wall, and it's difficult for me to imagine how we can reach the good part of footprint of a subscap. But okay, if you have the upper part lesion of a subscap, maybe you can use it, but I told you that when you have a coma sign and when you have an upper part lesion of a subscap, most of the time you can repair it without any problem. So for me, there is no really indication of that, even if, of course, a lot of my friends have published on that. So for sure, the pec minor, my major is one of the gold standard technique. We've seen the previous presentation, but again, the line of pull is not fantastic, as you know. And I think today the best option, probably biomechanically and theoretically, the best option is the lat dorsi because it is the little brother of a subscap somewhere, and it just mimics perfectly everything. It's a very strong transfer, very long transfer, and very easy to reach, either by open or even by an arthroscopic technique. So finally, I don't have time to show you the technique, arthroscopic technique, but it's not a big deal. We can discuss later. This is just to show you my experience for the last 10 years and to explain you that it is a very rare indication. I've made 317 posterior tendon transfer, lat dorsi, in the same time. Only 77 anterior lat dorsi transfer, because when you repair the subscap, you have a good result. So indications for the subscap repair are very rare. So finally, the discussion will be very easy. I found two papers for the lat dorsi and 2 papers for the pec major. So very easy to analyze. The goal of the surgery is to have a pain-free shoulder, to restore active interrotation, and to prevent, if possible, the anterior superior escape of the shoulder. So this is what the goal. This was my very first case with a mini approach procedure. And the first paper is the paper of Chang Hee-baek from Korea. It's a fantastic guy because he makes more than 2,000 shoulder surgery a year by himself and more than 200 anterior lat dorsi transfer open a year. So I visit him. It's just incredible. I advise you to visit this guy. And this result. And as you can see, he can negative the belly press test, but not every time. He can negative a lift of test, but not every time, because probably before the surgery, there is part of a posterior retraction of the capsule, and in that situation, probably it's too late, or you have to make physio with your patient before, trying to have a normal passive range of motion before trying to restore the active movement. So this is the paper we wrote together with Bassem, with 56 patients, 14 open and 42 arthroscopic. Yes, we have improvement of with clinical score, and when you have an escape of the shoulder, it's too late. We cannot recommend this shoulder, this technique, when you have an anterior escape of the shoulder or a posterior stiffness, significant posterior stiffness. This is the paper of Christian Gerber and Bernard Jost for the pec major transfer, and you can see that they have an improvement of everything, but the improvement of active interrotation is not fantastic. So everything is improved because probably it's a pain cutter, a pain killer of the shoulder, because maybe of spacer effect, but difficult to understand biomechanically how you can improve interrotation. Nevertheless, the results are very good, 10 years after the surgery, and this is the paper of Philippe Moroder and Resch, and you can see everything is improving with time, and especially the interrotation, you can reach 3 points with this tendon transfer. So I don't know by which mechanism, but somewhere this pec major works. For sure, it's not a bad indication. So in conclusion, my question is, yes, is the pec major transfer still the gold standard? Because it was, and maybe it is, but my way today, as you can imagine, is to make a full arthroscopic lat dorsi transfer, but we need proof this time because we don't have 10 years of follow-up with this technique. Thank you, my friend.